Good morning, good afternoon, and good evening from wherever you are joining us from. My name is Aisha Kokar, Associate on the Boost team, and on behalf of Boost, a warm welcome to our Bright Spot series co-hosted with the Solina Center for International Development and Research based in Nigeria. This session is part of a three-part series, and today we'll be discussing Northern Nigeria State's routine immunization strengthening program, collaborating with country governments in Sub-Saharan Africa for immunization and primary healthcare optimization, the pool funding model. Next slide. Now would be a great time, if you haven't already, to please introduce your name and where you're joining us from in the chat. And before we get started, I'd like to go over a few housekeeping slides. Next slide, please. During today's session, you will hear from Dr. Garba Bakanawa and Dr. Tijani Hussaini to give us the landscape on MOU financing and frameworks. Afterwards, we will break into a panel discussion with our guest speakers and have time for Q&A at the end. Next slide. During today's session, please stay muted to limit background noise. If you'd like to speak, you can always raise your hand or put your questions or thoughts in the chat. Next slide. Please also note, Boost does not permit the use of artificial intelligence tools during our webinars or course sessions. Today's session will be recorded and slides will also be available by the end of the week on our Bright Spots Boost Learning group, as well as emailed to you with the email you used to register for this session. If you're able to attend all 3 sessions of this series and fill out all post-session surveys, you will be awarded a certificate of attendance by Boost and the CIDR team. Finally, this series is only offered in English. However, we hope to have more multilingual content soon. Next slide. For those of us who are joining for the first time, the Boost community is a diverse network of more than 4,500 immunization professionals from 156 countries. Through our online platform, boostcommunity.org, we offer opportunities to our community to connect with fellow immunization peers and experts, learn skills that build capacity and advance careers, and lead immunization programs in any circumstance by sharing best practices and lessons learned through sessions like these. To access today's recordings and slides, we encourage you to sign up for the Boost platform and join the Bright Spots Learning Group. Next slide. For those that are new to the Bright Spots series, Bright Spots are stories that shed a light on the work that is happening on the ground and inspire immunization professionals to learn, adapt, and take action in their own communities. From engaging with religious leaders to improving supply chain to reach the last mile, there is innovation occurring at all levels of the system. To date, we have published more than 60 Bright Spots from 27 countries, which you can check out at brightspots.boostcommunity.org. Next slide. I'd like to also introduce everyone to the CIDR team who is co-hosting this series with us, and we'll be sharing discussions around MOU financing today, as well as capacity building and demand generation in the next few weeks. Next slide. I'd also like to welcome our guest speakers who you'll hear from towards the end of the session about financing models and frameworks in their own contexts. Next slide. This session aims to share cross-country learning on immunization financing with case examples from the MOU model from Nigeria and other African countries. We hope by the end of this session, you will gain an understanding of the broader financing trends in LMICs and gain knowledge of the MOU financing model's mechanism and how it can be applied to different contexts. Next slide. I'd like to welcome our first guest speaker, Dr. Garba Bakanawa, to tell us more about trends in health financing and LMICs. Dr. Bakanawa, over to you. Dr. Bakanawa, can you hear us?
Actually, I think Dr. Bakano is having some technical issues. Could you please ask him to unmute? I think he's unable to do that from his end. Thank you.
Yep.
Hello, Dr. Bakano. Are you able to hear us now? And go ahead with the presentation. Thank you very much. Yeah.
Hello, good evening, everyone. My name is Baknawa Garbabello. I will be taking us in the next session, and I will be presenting on behalf of the team. So just like based on the background that was presented, so the country in Sub-Saharan Africa, they face a lot of challenges. And one of the major aspects that we do look at is actually on the health financing component, which there's one of the significant components in terms of the successful program in health sector. So across Sub-Saharan Africa, poor financing is one of the major challenges that the African countries face. So, and actually to address that, we need to do a lot in order to ensure that the performance of health sector is really addressed. So if you look at the key challenges that we face in the health sector, one of them in terms of categorization, the challenges has to do with the capacity gap, as well as also the component that has to do with the health financing gap, as well as also the coordination of the resources chain. So according to some of the studies like the Obina et al., it has also highlighted some of the key issues that those components will really provide, like in terms of the high disease burden, poor infrastructures, and other component that has to do with health system strengthening really play a very important role. And in terms of the health financing, where gap exists, really this affects the overall system. So if you look at the map of the Africa, based on their budget declaration that was set up as a benchmark by all the African countries, it was only 2 countries that were able to meet up with the expectation. We have the Cape Verde and South Africa. Apart from those 2 countries, all the other countries, they really fall within the shortfall that is expected based on their budget declaration of the 15% allocation of budget to the health sector. And we can see some of the major issues that really relate to that, which has to do with the capacity gap, as well as also the financing gap and also the coordination. And the financing gap was also really aggravated by the recent COVID-19 and other factors that affect the fiscal space. Next slide. So if you look at the analysis as of 2022, this was really the analysis based on the state that we have in country, that is looking at Nigeria as a case study and also going down to the level of the state. You can see that across the 36 states and FCT that we have in the country, only 4 states in Nigeria were able to allocate above the 15% budget for health sector. All the other states, they really are below. So out of the 36 states, we have 4 that allocated to 15% and above. And we have also about less than 15% that also allocated, about 8 of them allocated 10 to 15, while over 20% of the state, they are really below the 10% allocation to health sector. So this is really worrisome, especially with the analysis that we have on the right side of the slide. You can see that this is a cross-section of some of the states. And if you look at the analysis of the budget, most of the states, they are really declining from what they have allocated earlier, or they are really not making significant progress. If you look at Akwa Ibom, the highest we have, which is in 2024, is 4.1. However, in some states like Zamfara, you can see like what we have there is really, the budget is really coming down. Worrisome is about Ebonyi. You can see like for 2024, we have less than 1% that is allocated to health. This is really a big challenge if you look at the entire health financing profile of the state in the country. Next slide. So going deep dive into some analysis, we are now picking one of the states that also benefited from the basket funding, which is Kano, which is located in the northwestern part of the country. If you look at the budget breakdown of the contribution of the health finance in that state, you look at the partners, the entire partners, they contribute about 27%. 52% by the government, and we have about 21%, which is jointly between the government partners. So if you look at the budget contribution, which was really encouraging, especially from the government perspective. However, the most important thing is not the budgeting, but what is actually released. So if you look at the releases, you look at the government that is contributing the significant proportion, which is 52%. It's only 1% that is release, which is really worrisome. If you look at the partners, even though they are partners, so 84% of the budget that was committed to health was not released. So the overall budget as well as the releases are really not encouraging. So government fund caters for basically the infrastructure, looking at the human resource for health, as well as also the operational component of the health services. Those are the critical components to make sure that the indices of health really move, and all those aspects are not really being provided significantly. So looking at the analysis of those three important components that I earlier mentioned, infrastructure, human resource, and operation, all those components are provided by the government. If you look at the releases based on the case study that we are looking at for Kano, so you see like 52%, which cater for infrastructure, human resource, and operation, but only 1% was released. So this is to show like, if you look at the infrastructure, there should be like challenge around infrastructural maintenance of the facilities. So the healthcare facilities are really going to face a lot of major strength in terms of the maintenance. Component that has to do with the demand of the patient will not really be catered for. And there is an exacerbated, this one was exacerbated by the insufficient healthcare equipment, which include the crucial cold chain equipment, especially if we are looking at the immunization component. So this shortage is not only going to impact the availability of the essential commodities in such areas, but also hamper the provision of the quality services. The same thing for human resource. Without the human resource, there won't be any services. So therefore, there should be like inefficiency of the inefficient human resource for health in those, looking at the quality of the human resource as well as also the quantity. So this also affects most of we see in most of our states. So the critical human resource are leaving the government because all those things components are not really catapult. The combination of suboptimal pay, increased workload, and poor investment in the targeted capacity development also affect the entire spectrum of the healthcare system if you look at the human resource component. The same thing for operation. The basic commodities may not be there. The drugs as well as also other consumables may not be there. Next slide. So to have an effective healthcare financing, 5 major components are really critical. And those components really need to be integrated, play an important role. What are those components in terms of the to have an effective healthcare financing? One, we need that financing to be led by government. So to allow the government to really set the priorities as well as be on the driver's seat. We will also look at the performance. It has to be performance driven. So result delivery is rewarded with continuous improvement in terms of the funding. So where there is no low performance, then definitely, then the result may not likely going to be there if the funding is not really available. So in terms of the coordination, financial pathway is well structured with clear processes, as well as also participation of the all relevant stakeholders, especially in the context of health. Then the other aspect, we will be looking at the strong accountability measures that will ensure that government and partners and all other stakeholders are really accountable and they are responsible. So the next slide will be able to give us the opportunity to see where we are able to rate the 5 components of the health sector. Next slide. So looking at the review of the availability of the available funding modalities, so we'll rate them based on those 5 parameters. So the financing type, we'll be looking at the government financing. So just like we mentioned, for an effective health financing, those 5 components need to really be ticked and be ticked positively. So looking at this, so in terms of the government funding, so usually it's government-led and also is sustainable because every year government will also, of course, budget and also will release some component of the budget. So in terms of government-led and also sustainability, those are the only component that we can take. So the other aspect that has to do with the coordination as well as also accountability is just partial and it's not really performance driven. If you look at the direct partner funding alone, so you look at it, it doesn't meet up with any of the 5 parameters. And the only area where we can look at it is just around the performance driven and coordination, which is partially achieved. But in terms of result-based partner funding, it can only be ticked under the performance driven. But in terms of the other components, its coordination is partial as well as also accountability is just partial. It's not government-led, it's not sustainable. So we'll be looking at the context that we are looking at, which is the full funding. So in terms of the full funding, you can look at it compared to the other type of financing. You can see like this is also government-led. We can also say it's well coordinated and it's also highly accountable because in terms of the pool funding, the partners, the donors, as well as also the government need to come together based on the MOU. So the MOU funding provide that capacity or opportunity to take all the relevant World Bank, parameters of effective health financing. So you can see like even the performance as well as the sustainability is also, though it's partial, but at least it's better compared to the other type of financing. Next slide. So I think based on the background that I have said, the next presenter will take us to the other component of the model of the MOU, so that we'll be able to see how does the model of MOU really achieve those effective financing type, as we can see in the next presentation. Thank you, and looking forward to the other part of the presentation. Over.
Thank you, Dr. Garobakuna, for the excellent presentation. So my name is Dr. Tijan Hosseini. I'll be taking you on the MOU model, principles, enablers, and lessons learned. Beginning from 2012, 6 Nigerian states, namely Sokoto, Kaduna, Kano, Borno, Yobe, and Bauchi, in partnership with Aliko Dangote Foundation and Bill & Melinda Gates Foundation, started a multi-party full funding mechanism to improve RI financing through an MOU. This MOU is government-led through all-inclusive technical working group leading on planning for immunization and judicious use of fund. to ensure all RI activities are aligned with the state strategic plan. All activities are collated into a single plan through which success is measured. Strong transparency and accountability were instituted. At the initial stage, partners took greater funding, with states gradually taking over. At the end of the MOU, state governments took over completely RI funding in their respective states. However, because of legal requirement of some non-basket funding partners, they were unable to contribute directly into the basket funding, but they directly fund immunization activities as outlined in the collated immunization work plan and provided other technical assistance. Moving on to the next slide. To deepen transparency, accountability, and involvement of all stakeholders, a biannual VTC was instituted, where the principal partners to the MOU, that is the state government, the partners, BMGF and ADF and other non-funding partners attended. Other participants to the VTC are the traditional leaders who are integral part of implementation. The National Primary Healthcare Development Agency, which provided technical oversight to state on the implementation of primary healthcare, and relevant program officers at state level. These VTCs were intended to ensure political commitment and provide political oversight on program implementation, advocate for PhD financing, further align the MOU activities with the state's health development plan, review achievements, and serve as platform for addressing program challenges. Next slide. Before the states, before the MOU, there is no visibility onto the funding disbursement and utilization at the lower level, as funds were disbursed to LGAs, and while the LGAs withdraw money and give to facilities. This gives rise to unaccounted resources. To improve on this, the funding ensures that there is revision on timelines, there is revision on modalities of fund disbursement. Funding after the MOU, during the MOU, funds at all levels is tied down to a clear budget lines to help track expenditure and performance. There is now direct disbursement of fund to point of utilization instead of the previous mechanism of funding the LGAs, and requests are validated through finance working group, ensuring rational use and utilization of funds. Spendings were digitally made and validated with mechanism to recouping improperly spent funds. This new system ensured judicious utilization of resources and accountability of those resources to deliver on all planned activities. Moving on to the next slide. Through the MOU period between 2013 to 2022, over $54 million was invested in the 3 states, and 100% of all the funds were accounted for. Facilities were able to execute successfully finance functions, most of them, about 77%, while 90% of the audit exceptions resolutions were implemented. And between that period to 2012 to 2022, 16 high-level VTCs engagements were conducted with the principals of state governments and the partners. Through this funding model, over 4,900 facilities were supported across the 6 states, with 77% saturation of coaching equipment, and cumulatively, which is impressive, over 131% cumulative increase in DPT coverage, as shown by the 2021 NICS survey. As adjacent benefits, and looking at how we were able to achieve transparency, accountability, leveraging resources from government, expansion of this MOU was beyond RI. It incorporated broader PHCs, other parties, other partners, 6 additional partners joined the MOU across the state, while the success also was exported to, of this model was exported to other African countries for implementation. Now I will hand over to Demilade Oshidioku for the panel conversation. Thank you.
Yeah, thank you very much, Dr. Tijani. Very exciting conversation there. Thanks very much, Dr. Brakunawa, as well. A very good overview of the health financing landscape in LMICs with a focus on African countries. We'll now go into the panel session, and our panelists are well known. I think we have Leah Head, who is the Deputy Director at the Bill and Melinda Gates Foundation. She oversees the RI Strengthening and Polio High-Risk Geographies. That's the risk initiative within the foundation, and that covers about 10 countries. We have Dr. Oben Pamela, who is the EPI Program Coordinator for the Southwest region in Cameroon. She has extensive experience in capacity building, vaccination, disease surveillance, coaching, management, monitoring, evaluation, and of course, financial management. There's also Dr. Garba Bakunawa, who we heard from earlier, who works with the Nigerian National Primary Healthcare Development Agency. And we also have Dr. Tijani Hussaini, who is a medical doctor who was the immediate past Executive Secretary of the Kano State Primary Healthcare Board during the MOU years in Nigeria. I'll start with you, Leah. BMGF played a very vital role in establishing the MOUs in Kano back in 2013. And we've seen that extend now, still ongoing. Can you delve into the rationale behind its inceptions and how it has evolved, which led to expansion to 6 more states and I think 9 more states now? Over to you, Leah.
Thank you, Demilade, and great to see a lot of familiar faces on this call. So the MOU Basket Fund idea actually came out of polio eradication effort unexpectedly. In 2012, the foundation was investing heavily in polio eradication, and we had some observations from that. One was, heavy investment in the eradication effort was really verticalized, and there were a lot of one-time activities. But there was a recognition that if we did achieve interruption of transmission, there needed to be a strong routine immunization system to maintain that. And that required a fundamentally different approach to how we invested, because routine immunization by nature needs to be owned and managed by ultimately governments to continue forever. And so we had been looking at other donor investments that had been taking place over many years, decades even, and seeing that in northern Nigeria, sometimes the coverage wasn't changing with those investments. So we tried to use some observations. The first was about government leadership. When donors are not putting money into government accounts, there is very little incentive for the government, and sometimes very little transparency for the government. And so their ability to own and manage that work effectively is decreased. So first, our hypothesis was that if donors put money into state government accounts and they manage those funds, it would increase government ownership and effectiveness in managing that funding. The second was sustainability. So we wanted a model that encouraged governments to sustain the work even after donors may not be involved. And so we also included a government co-financing element, as Dr. Tijani explained. And the third was donor coordination. We observed that state governments were having a lot of challenges aligning all the donors around a common plan. And so we wanted to channel our support in a way that would naturally align donors in support of government priorities. And the idea of the basket fund was that donor funding wouldn't be earmarked for specific activities. It would all be in the basket fund. And then the government's plan for the entire sector would draw from that fund in a way that could optimize the use of the resources and provide transparency around a one plan approach. So we did what is actually still quite rare for the foundation and many donors, which is put our money directly into government accounts. And we linked arms with partners like Aliko Dangote Foundation and others to do that alongside us. And you heard from Dr. Bukunawa about the pros and cons of that, and from Dr. Tijani about their experience in Kano with that. And overall, the foundation's experience was that this is a strong model. We'd like to see if after the experience in Nigeria, it could apply to other places. So we expanded it to Guinea, Niger, Chad, and DRC. And the main prerequisite was whether those governments had the political commitment for the agreement and also the co-financing. And just briefly, I think our experience has been that very strong. In Niger and in DRC, Gavi is now a co-signatory to those agreements, which really helps streamline immunization funding. Chad has been incredible in terms of releasing large amounts of co-funding. We're still really learning about how to set co-financing levels and understanding fiscal space as it applies to routine immunization, and also how to consider routine immunization versus broader PHC. And the model applies differently in different settings. In DRC and Nigeria, with state and provincial governments, it works in one way. In centralized governments, it has to be adapted. But in general, it's been a really exciting experience, and I'm glad we're highlighting it in this session to learn more.
Yeah, thank you. Yeah, thank you very much, Leah. I think very great points you mentioned there: the need for integration, the need for adaptation, whether it's a centralized system of government or a more decentralized one. Very importantly, how do we make sure that the financing continue together, just getting these resources from the government and getting their commitments spot on all the time? I'll move now to, for my second question, I'll move now to Dr. Pamela. We've learned that Cameroon employs an alternative funding mechanism instead of a basket funding MOU. Could you provide some insight into this system? What strategies are in place to ensure its efficiency, and more importantly, its sustainability? Over to you, Dr. Pamela.
Thank you so much, Demilade, and I'm very pleased to be able to share my experience from Cameroon. You earlier during the presentation, it was seen that only 2 countries in Africa actually are able to have sufficient financing for health in their budget. The same applies to Cameroon. In Cameroon, we have about 5% of state funding that is allocated to health, and this is actually very little. And it actually entails that most of the population has to do out-of-pocket spending to ensure they have good health. When it comes to the immunization program and even other programs, what is really done is co-financing, the co-financing mechanism where the country as well as partners chip in funds which are used to provide primary health care to the population. And these funds are mostly provided by the partners in comparison to the government. For example, in the EPI program, we can see that about maybe 75% and over is provided by the partners in supporting health activities. Now, looking at the innovative things that have been done in the country to ensure that immunization is actually scaled up, or that there is reduction of morbidity and mortality in children, we have the universal health coverage the first phase that started in last year, 2023. And through this, the funding provided by the AFD, Agence Française de Développement, and another German international organization, there is able to be provision of treatment and also primary healthcare interventions like vaccination for free to specific target population like children below 5 years of age. In the immunization program, we're also doing a lot of integration, and where funds maybe are used for polio campaign, we're able to use these funds to be able to provide, to do some kind of catch-up vaccination for children who have missed. We have a lot of zero-dose children, and this provides some kind of one-stop shop where we can reach out to these children and provide them the health services they need. We have a lot of local level implication. Cameroon is very different from Nigeria. Nigeria is a federal state. In Cameroon, we have a more centralized government, but because of decentralization through the regional councils, there has been a possibility for these regional councils to actually get implicated in health activities. So there is some kind of local pooling of funds where these regional councils, the mayors, are actively involved in health activities. And during, for routine immunization, for campaigns and other health activities, they are able to support and improve the health of their populations. I think innovation in terms of paying of actors and also just supporting finance through financial resources, we've been able to digitalize our payment system, and this has also accounted for greater accountability, greater management and coordination of funds. And this too has contributed to the motivation of actors at the lower level, because where you can receive funds, you don't have to yourself through your mobile phone, you don't have to pass through a third party. This creates better motivation and has also helped to improve their performance at the local level. Thank you.
Thank you very much, Dr. Pamela. Very exciting conversations around co-financing, around how regional governments can step up even in a centralized system, and how those in transition as well can add their quota into just strong domestic resource mobilization. Dr. Tijani, as the former executive secretary of the Primary Healthcare Management Board in Kano, could you discuss how the government's thinking around sustainability of this funding post-MOU, particularly when it comes to timely payments? Over to you, Dr. Tijani.
Thank you, Demilade. If you look at the presentation of Dr. Bakunawa, one of the slides, he said there are 4 states that sustained, as at 2022, that sustained above the Abuja funding cap of 15%. 4 states. 3 of the states, Sokoto, Kano, I think one other state, Bauchi also, out of the 4 states are the MOU states, which is significant. It means within the context of these 6 states, 3 are able to at least finance, allocate more than the 15% to health, which is significant. Coming down to Kano, one needs to understand again that full funding mechanism is only as good as how is coordination. How are people able to manage the resources? How are people able to advocate for release of these resources, which ultimately getting you to the release itself. So through the MOU, I can say that there has been an institutionalization of technical working groups, especially the finance working group, service delivery working group, so that they go through the budgets, ensuring that is adequately planned, resources are adequately allocated. the MOU has helped institutionalize, and the conversation is still on. When it comes to coordination again, as institutionalized by the MOU, this is still ongoing because the parties, the funding in health is usually organized, is well coordinated now. Partners, you ensure that partners put in their activities in the annual operational plans of the state, which is also very significant. And also through the MOU system, we were able to have that capacity to engage with the state governors, ensure that resources are allocated. We explain how the resources can be utilized. So for me, these conversations are still happening in Kano specifically, and I feel this is what the MOU is able to establish within this stage. However, when you come to the release of the fund themselves, there is improvement, yes, compared to when it was before the MOU. Yes, releases had increased, but they are not at the optimal level, which the state on its own keeping tab on the highest authorities to ensure that releases, funds are made available to states. But compared to what it was earlier, I would say massive improvement, and still the conversation is on.
Yeah, thank you very much, Dr. Tijani. And I see a lot of conversations already happening in the comment section. Please, if you have any questions, please drop it in the comment section. We'll try to answer as much as possible. I'll still go back to you, Dr. Tijani. I mean, having directly managed the MOU model for a couple of years, if you had the chance to do this over again, or if people on the call from Eswatini, from Mauritius and other countries want to experiment with something like this, what are the optimization measures that you put in place? What would you do differently this time?
I think what was done earlier was conversation within the health sector mainly, with another layer of conversation with the chief executives. For me, if I were to do this differently, I would say, can we bring in those who has the custody of financing, Ministry of Planning and Budget, Ministry of Finance, early on the conversation, so that they understand what we are thinking, they understand what we request. They also release so they help facilitate release of these funds. For me, this will be key to improving the overall performance of the MOU as they are.
Yeah, thank you very much, Dr. Tijani, for that. I'll go back to you, Dr. Pamela. I mean, given all the things you've heard today, what lessons do you think you're taking for yourself in a country that's centralized, that's in transition to decentralization, uses co-financing model? What lessons are you picking from the conversation so far that you can apply? And what lessons do you think folks who are implementing the MOU should also take back home with them?
I think I'm very impressed at how the MOU model was able to improve the immunization coverage. I think he mentioned till like 131%, like this is quite unheard of. And I see that it's a model which is effective. We've not used that before, so I'm hoping that we would be able to use that particular model in Cameroon and see what we get out of it. Because we've been using the model we use, actually it's working, but we still have a low immunization coverage that is below 85%. So we're looking forward to this model being applied in the country. And I also, from what I heard him presenting, there was improved coordination, improved management, which followed as well. So I think management and coordination are actually very important aspects. He also spoke about financial management, accountability in financial management. I think this too is a very important important take-home message, because when there is adequate financial management, there is also trust, and it ensures continuity in funding from the partners. So these are very key messages we need to take home.
Yeah, thank you very much. I think that's very clear. Leah, I think Leah also mentioned something on the comments section from the question by Dr. Zinbo around accountability. How do you make sure that fraud doesn't exist within the system? But also, Dr. Tijani mentioned something else around the MOU providing access to the executive leadership, such that the immunization becomes a top-of-line agenda, and there's a lot of access to the executive and political leadership. For you, Leah, from your experience, what strategic advocacy strategies would you recommend that stakeholders in LMICs use so that they get this kind of government buy-in and elevation of immunization financing on the agenda on the agenda of government?
Great question, Demilade. I think I'll build on Dr. Tijani's point about not just talking with the health stakeholders, but really taking an all-of-government approach. If we talk to the health minister, we know the finance minister is there, or the commissioner is there, holding his hand or her hand around how does this money get released. So those finance and budget discussions are equally as critical. And also, as Dr. Tijani mentioned, go to the executives. I think finding partners who can consistently bring the same talking points to the executive, the finance, the health is critical. Find the donors that can go sit with the highest level officials. Find the advocates that can go sit with the highest level officials and make sure everyone has the same talking points. I think seeking public commitments, whether it's through a memorandum of understanding agreement that everyone knows has been made to release funding in a timely way, or other kind of public commitment is helpful. I think knowing the budget cycles, if we ask for funding, but the budget has already been made, it's going to be very difficult for governments to react positively to our request. So know when those budget cycles are happening, and talk with the folks who are bringing the budget through that cycle at every step of the way. If the finance team, minister or commissioner knows that when the budget is going through the system and when the payment should be made, they'll be much more reactive. A second thing is partnership. As I've said, making sure that all of the stakeholders who are interested in this have understood what the priorities are, the timelines, and have the same talking points is critical. I think bringing donors into those discussions, because there can be some sense of, okay, we're putting our money down, now government, you put your money down. That's a really strong way to have the conversation. I think, as we've talked about throughout this, one other thing to consider is trusting the government and putting them in the driver's seat. Taking this discussion around this model and thinking about how it could apply to your setting, or the strategies that Dr. Pamela talked about. And then I think lastly, and this was something that was a big learning curve for the foundation, but very helpful, is bring in stakeholders like traditional leaders. In some countries, the traditional leaders are not involved in health, but they should be, because their voice really represents communities and goes really far with political leadership. So the more we can bring them along with the process, the better for both community engagement and for government accountability.
Thanks very much, Leah. It's really widening the scope of people that you bring in. Bring people from the finance ministry, bring the traditional leaders, bring opinion leaders, bring people who can give access to the executive of the executive government, and all of those. The more the stakeholders involved and the clearer the roles that they have, the better we can succeed at mobilizing domestic resources, not just money, but also goodwill and prioritization for immunization activities across the board. There's a question for Dr. Tijani, but I think that Leah, you could give a stab at it, and then we'll go to a few of the other questions in the comments. The question is really, how do you maintain high commitment of the government especially with changing government? I know you, Leah, has seen, working with the MOUs, multiple governors, different administration changes. How do people really get commitment to be high, irrespective of which government is in place or transitions that happen? And Dr. Tijani, you could also accentuate that. Thank you.
Yeah, this is such a big challenge. I think one thing is having those commitments on an agreement with the institution rather than the individual holding a seat is critical. So that's why the memorandum of understanding, the fact that it's on paper and signed by the ministries, and it's signed by the ministries of health, ministries of finance, in some of the centralized countries, Ministry of Interior, having that on paper so you can take that paper to the new government after they're elected and say, this is the commitment of government, not just your predecessor, is key. I think continuously briefing new governments and having not just a briefing, but an orientation. This is what this is. This is why it's valuable for you and for us as a partnership. I do think this is one of the biggest challenges of keeping of this work, especially with the financial shocks and new administrations needing to adjust to different budgeting finance realities. So I'm curious for your answer as well, Dr. Tijani.
Yeah, thanks, Dr. Tijani. Over to you. Your microphone is on mute. Yeah, go ahead.
Yes. Thank you, Leah. This has always been a struggle, but from my experience in Kano, the VTCs are always big events. Preparation through the ministries of health, traditional institution, the governor is engaged deeply in it. This, despite their busy schedule, actually keeps them in focus to see that health is part of their agenda, because the governor, whoever that is, because we've seen at least 3 governors now in Kano, from 2012 through 2022, we've seen 3 governors, and each of these governors keeps a focus on what the MOU is. He's asking, when are we having our VTC? What are your requests? What are we to do? This high-level engagement keeps the governors to be always abreast of what's happening in health. And for me, if there is any lesson to be learned outside the MOU, is how do we begin to organize such kind of high-level meetings with top-level officials so that they are aware of what progress we are making, what are our challenges, and what support we require from them. For me, big issue, this VTC.
Yeah, thank you very much. And I think the point we're taking away is, if you make the discussions about immunization a politically relevant discussion, irrespective of who the executive leadership is, they will want to continue from there. So I know in Nigeria, we bring the likes of Bill Gates and Alhaji Aliko to attend those events. So irrespective of the governor who is there, or the president or the minister, these are the kinds of people that they want to engage with, and these are the kind of conversations that they look forward to. And in the other countries too, is really the ministers are there, it's multiple ministries. I think in Niger, there was a high-level presidential forum on immunization to kickstart this. So because it's a high-level forum and dignitaries from the foundations, from partner organizations, from Gavi, from BMGF, from WHO, Afro are there, that's something they want to keep up with. That's something they want to get on the news. That's something they want to get on social media. That's photo ops that the political leadership wants to do, and therefore they can commit to those kinds of activities. So that's one of the tricks in the book. And thanks, Bilal, for asking that question. We're running out of time very quickly. Maybe the last question there, I'll take it to Dr. Brakunawa. I think Dr. Hadiza Yaro asked, what's the possibility of merging the MOU funds with Basic Healthcare Provision Fund, that's Universal Healthcare Funding, and other program funding like Impact in the States, and using the accountability system that the MOU brings? So can we expand the pool of people who contribute to the basket to include other things? And can we use the accountability system of the MOU to make sure this is properly managed?
Yeah, so thank you very much for that question. I have seen the question from Sokoto. So for me, the MOU has really laid a kind of foundation, not only for the state, but really for even the national government to look at and adopt. I can recall it was MOU at the state level, which is by BMGF, Dangote Foundation, and the states. However, we also copy something similar at the national level. You may recall working with Gavi around vaccine financing and health financing for FACE when we developed the NCIP Nigerian Strategy for Immunization and Primary Healthcare System Strengthening. So one thing that we did is like looking at the MOU model, we said that, okay, it's good, just like not to develop a strategy, but also to embed a kind of accountability to it. So we now develop AF, Vaccine Accountability Framework for the NCIP implementation. So moving forward, just like Dr. Hawa mentioned, I think in line with the current strategy of sector-wide approach of the current coordinating minister for health and social welfare, as well as also to align that the new executive director of MPSCDA, Dr. Muyi Aina, has made it also very clear that moving forward is not going to be business as usual. And at the same time, we have to align to ensure that accountability for sustainability is there. So one thing that we are also looking at is to see how we can be able to align around the sector-wide approach. And one of the areas that we are looking at is to merge the funding for basic healthcare provision fund with impact. So presently, impact has started implementation for like about 3 years. But after this, this administration came at the right time, it's just like at the midterm review, but all the other activity has been stopped. And moving forward, we are looking at how we'll be able to bring that concept of one basket funding in terms of the MOU approach, where we'll bring that impact funding and also merge it with the existing basic healthcare provision fund. The impact funding is from the World Bank. And the idea of impact funding is also to see how they can really like stimulate, just like the way also MOU does. MOU does, some of the funding are like catalytic to ensure that states take ownership and sustain. So we are also looking at to use leverage on the impact funding to see how we can sustain that basket like MOU model so that those funding will now brought together. So with the contribution from basic healthcare provision fund, which is one consolidated revenue of from the nation, impact funding from World Bank, which is a loan, and at the same time with the government funding, all bringing it under one MOU consideration, I think it will be a way forward, and it will also enhance a lot of accountability, liberating from the current what we do at the national, which is vaccine financing and accountability taxing. I think it's a good idea that we need to liberate as a country moving forward. Thank you.
Yeah, thank you very much, Dr. Bakunawa. There are also quite a number of interesting comments in the chat box. Haruna, thanks for the testimony about how the MOU helped increase cold chain saturation at the ward level, just at the district level the ZR levels in French-speaking countries. And thanks, Adefunke Morufat, for your comments as well. We are very close to the end of time. So I will now hand over to Aisha to wrap things up from her end. And thank you very much, everyone.
Yeah, thank you, everyone. I just wanted to thank our moderator and guest speakers for sharing your insights and lessons learned. Just a few reminders. Please remember to join the Boost community to access today's session recording and slides, which will be available at the end of this week. We encourage you all to continue conversations and asking questions on the Bright Spots Learning Group Forum, and all the links will be in the chat. Please remember to take the post-session survey, which will pop up on your screen after the close of the session, so we can work to improve our offerings. And finally, we hope to see you all in 2 weeks on February 29th at the same time for our next session on building capacity of primary healthcare managers at state and sub-state levels. Thank you again to all our speakers and participants for your engagement throughout the session. I hope you all have a wonderful week.
Thank you very much, Aisha. Looking forward to the next session.
Thank you.